Well, Washington has been a fascinating area the last 12 to 18 months, specifically in cardiology, but actually, as we all know, to healthcare in general. They continue to throw us curveballs that have been very challenging for the cardiology world to adapt to and to adjust and to change our strategic process in order to meet some of these challenges coming out of Washington. Specifically right now, as we all know, the sustainable growth rate, or as we call it, the SGR, is broken. We're on our third payment hold, and it's very difficult for practices to be able to play with their cash flows and account for their cash flows with that kind of an SGR. On top of that, we have our physician fee schedule, which, as we all know, came out last year in 2009. We were hoping to mitigate some of that, and we were very successful through a lot of advocacy processes to mitigate the hit of the fee schedule. But in reality, there's probably 4 key components to the fee schedule. One was the PPIS data, which I think we all know about, which was that AMA survey that was done. Very small response from cardiologists, but yet a massive hit into our technical component. One of the advocacy wins that we had was that they ended up implementing that over 4 years as opposed to an automatic hit in year 1. The second hit that we had in the fee schedule was the bundling of our nuclear codes, which initially resulted in a 36% reduction, but through some more successful advocacy, a lot of work with ASNC, the Association for Nuclear Cardiology, SECT, which is a CT Cardiology Advocacy Alliance, who I work with, and the American College of Cardiology. We just received a technical correction on that, and that was able to give us another 10% back on our nuclear. Third hit was the practice expense component. There was another practice expense hit, which is a process where they again decreased the technical fee. It was a change in methodology. This was our 4th year of that. And in addition, they had some medical malpractice RVU changes. So all in all, the fee schedule served up a huge financial hit for cardiologists. Another major advocacy coming out of Washington is the appropriate use criteria. We now try to make sure all of our labs are accredited, all of our physicians are certified to read our tests, and the third piece of that is the use of appropriateness criteria, which is where our physicians and our staff use the guidelines that have been set by the American College of Cardiology to ensure appropriate imaging. What's happened with that, however, is the payers have hired a third party, what we call radiology benefit managers, that have added an enormous burden to practices. And we're hoping that through some advocacy issues we can mitigate that radiology benefit manager and hopefully move more towards appropriateness criteria. Then the last thing, you asked a long question. The last part of that is the whole issue with healthcare reform. Healthcare reform is a very mixed bag. There's a number of things in it that obviously opening access is an issue, but as we open the floodgates of a lot of people that have not had insurance but who are chronically ill, and physicians are getting paid less and less, we truly worry about access for our patients in the new healthcare reform. As healthcare reform unfolds, there's probably 2 things that we need to watch very closely in Washington as it relates to cardiology. One of those is what is called CMI, which is the innovative payment model that will be starting pilot sites in 2011. We need to be very careful on how that evolves. The second is the Independent Payment Advisory Board, or IPAB. We call that MedPAC on steroids. This is another mechanism that Washington is going to use to affect physician payment, and it's only physician payment. So if you take the SGR plus the IPAB, you can see that physicians are really being heavily impacted or potentially impacted. The IPAB board will be able to make regulatory and financial recommendations to Congress that will automatically be implemented. The hospitals were removed from the IPAB process during the negotiations, the final negotiations of healthcare reform, and we're hoping to mitigate some of that for cardiology as well. I think as we take that payment reform process just a little bit further down the pike, we start looking at different payment delivery, patient care delivery processes and payment reform as part of that. And a lot of that payment reform is starting to evolve in beta and pilot testing. Among those is the patient-centered home. Many believe, including myself, that cardiologists can in fact be the patient-centered home for the entire care of that patient. Another one that is being piloted is is accountable care organizations. And accountable care organizations, many feel, is an HMO on steroids. I think we need to watch those models carefully to make sure that we're not rationing care, that we truly provide the care that has the best patient outcomes. And the reality is that we don't know, really. Healthcare is not just a science. It's not just a science, it's also an art. And I think as we look at accountable care organizations, you need a very broad-based patient base, you need a broad base of physicians, and you need a payer that is willing to work with you as you develop and design accountable care organizations. Well, I think we can take that theme we've been talking about all along with the fee schedule hits, the payment reform issues, the models of care that we're going to be delivering, and take that now up to the current status of the integration of practices. And I think what we're seeing across the country is that we realize we must deliver health care in a different way. And whether or not private practice cardiology per se is dead, I think the crystal ball still isn't quite clear on exactly how that's going to evolve. But there is no doubt that we need to partner with our hospitals. And in order to redesign patient care delivery models and payment reform, that redesign needs to start in our local communities between our hospitals and our physicians. I think that is what's driving a lot of the cardiology practices. In addition to the issue we have with the physician fee schedule, there's no doubt in the integration model that the rationale as to why many practices initially look at integration is because of what we call the provider-based reimbursement component. PBR, as we like to refer to it, is that process where we can have the same test on the same machine by the same technician done, and yet the hospital gets paid 3 to 4 times more than that. So I think physicians, rightly so, are migrating towards that payment model or a reimbursement model for them. But as a part of that, we need to be very careful with the governance structure of how the integrated models work and how we're really going to partner with that. So I think as groups go through the integration process, they may start for the financial reasons, but most of them end up for the right reasons, which is it gives the physicians the opportunity to not just govern their practice, but to actually govern the product line within the hospital, which allows for great patient flow and throughput in the hospital setting, which has been sorely neglected. I think it will also allow us to care for our patients much more cost effectively, because now we're truly a team at the table with the hospital as we look at integrated models. So I think governance is very important. Obviously, physician compensation is very important, and the delivery care model for our patients are probably the triangle of why integration continues to evolve. As a former hospital CEO, I think hospitals are finding themselves in extremely challenging positions right now. A hospital administrator needs to create an environment where physicians want to practice, where they want to bring their patients, and on the same plan, they also have to figure out how to get the physicians at the table to work with them strategically and financially. And that's very difficult because we start to talk about control and we start to talk about the power and the responsibility. And hospitals tend to be relatively silo organizations. I think many hospital CEOs are trying to break those silos down within their organization, and the very successful ones are able to do that. I think the integrated models will further help them do that, because for a truly successful integrated model, you need to cross the nursing lines, the radiology lines, the emergency department lines, marketing and business development, financial, and it takes that whole subset of entities and rolls it up under one umbrella, which is a truly well-functioning cardiology product line. I think if you talk to hospital CEOs that have successfully done it, they wish they had done it years ago, because once they get those physicians at the table with them and they're truly lockstep in designing and developing and implementing a strategic plan, they start to capture their market share and truly deliver the kind of cardiology care that they really want. So I would encourage hospital CEOs not to be overly trepidatious as they enter into these partnership discussions, but to really embrace it as another change in looking at healthcare delivery in a different model.